Hospital. I'm excited about today's conversation. It's a very interesting topic, and as I can see already in the Q&A section, we have a question about the topic from Dr. Annette Busula. Thank you, Dr. Annette, for your question. Before we invite our panelists to start us off in this conversation, I'd like to introduce my co-host, Dr. Nancy Ngumbao. She'll handle the Q&A section. Janet Ongera, we've seen your concern about CPD points. We'll follow up with the team that's handling the CPD points for pharmacists and pharmaceutical technologists, and we should be able to streamline that very soon. The process is becoming clearer and easier as the days go by. It's not like the way it was before. So welcome to today's conversation. We have Professor Kariuki Njenga and Dr. Isaac Ngere. We also have Dr. Maritim as part of the panelists. We're going to have a few more guests, part of Dr. Njenga's team, who, as they join in, we will add them to the panelist section, and they should be able to address you any Q&A or any concerns that you might be having. Professor Njenga, this is a usual KNH webinar, and we have participants from all over the country, and I'm sure they're very interested in this topic. It's a very exciting topic, so I'd like to hand over to you so that you can start off this session. Karibu, Professor Njenga.
Thank you so much, Dr. Kalondu, for the introduction of our team. All the co-authors of this paper are here. We were invited to give this seminar because of a paper that we published just about 2 weeks ago that was exploring why we seem to have fairly low morbidity or transmission and also low mortality of COVID-19 in Africa. This was a joint effort, and what we are going to do this afternoon is ask one of us, Dr. Isaac Ngere, who is a clinician like most of you, to do a presentation that really summarizes our findings on the paper, but also just summarizes where we are with COVID-19 globally. And then after that, we will allow questions and maybe also comments by the rest of us who are co-authors and panelists in this discussion. So without much more discussion, I want to invite Dr. Ngere to go ahead and share his presentation, and then we can discuss at the end of it.
Thank you, Professor Njenga. Thank you, Dr. Kalondu, the chair of the session, and the rest of the co-hosts. I'm going to share the presentation shortly so that we go straight to the discussion. Okay, I hope we are able to see the slides. Okay, so I'm going to make this presentation, as Professor Njenga said, on behalf of the team that we worked with together. And the presentation regards why we have low morbidity and mortality of COVID-19 in Africa, so far from the data that is already available. So as Professor Njenga said, this paper was published in the American Society of Tropical Medicine and Hygiene Journal. I came out on 1st of June online, and the slide that I'm sharing there, essentially I'm acknowledging the co-authors that we worked with and some of the institutions that we worked with to come up with this publication. I know most of my co-authors are already logged in, and they'll be able to address concerns from the participants. So as an outline, I'm going to take us through the global situation of COVID and also to look at a few countries in Africa. Then in the second section, I'm going to delve a little bit into some of the hypotheses that we pushed through in the publication. And then to give a conclusion, the tail end, I'm going to invite again Professor Njenga to talk a little bit about some of the changes that we've seen in the epidemic evolution beyond the publication that we did. Because as we know, one day in COVID is essentially a lot of things can happen. So he's going to talk a little bit about the case of Brazil, and then we can have questions and answers at the end. So the publication that we did was a perspective paper, and essentially we were sharing some of our views in terms of the hypotheses that we felt were offering a reasonable enough explanation for why the initial phase of the COVID-19 outbreak was a bit slower in African countries compared to the rest of the world. So the first slide here I'm going to share, I think a lot of this information is in the public domain and essentially gives us the timeline of the COVID-19 pandemic within the first 3 months of this year. So as we all remember, this started with a cluster of cases in Wuhan, which was made officially reported by WHO on 5th of January, where they notified the world about a possible outbreak of a respiratory illness in China. On 30th of January, we all remember that's when it was declared as a public health event of international concern. And on 11th of March, this was escalated to a pandemic level. So along that, again, we also had the epidemic spreading across countries. By 13th of January, we had the first case, which was reported outside China in Thailand. And 7 days later, we had the first case, which was reported in the United States. 29th of January, we had the first case in Italy. And the countries that I'm picking here are essentially US, Italy, India, 30th of January. And then in February, we had the first case in Africa, which was reported in Egypt on 14th. And later on, shortly on 26th, we had a case in Brazil, 28th in Nigeria, 5th of March in South Africa. And then finally, the first case was reported in Kenya on 13th of March. So essentially the countries that I've listed on the top part of this slide are the countries that we are going to focus in terms of our discussion. And they are the countries whose data we looked into in details, alongside all the other data from the rest of the world to come up with some of the hypotheses that we explored in our publication. So the table that you see in front of you is quite busy, but gives us a little bit of the statistics across some of the countries or regions that I'm going to refer to severally along as I make the presentation. And essentially what I need you to look at here, aside from it being a very busy table, we need to look at the two areas that I've highlighted in red. And first of all, you can see Kenya there. We have just about 4,400 cases. And these were by 21st of June, which was Saturday of last week. This slide is updated up to Saturday of last week. And Kenya, as you know, we are doing, by that time we were doing 100 days, just slightly over 3 months since the first case was reported. But then if you look at the bottom, globally, we were doing day 163. That is just over 5 months since the first case was reported in China. Now, what is interesting in this slide is that I've picked a few countries like US, which just has over 2.2 million cases. We can see the column there with the case fatality ratios and then the deaths per million, which is trying to put the number of COVID deaths using the denominator as the total population of that particular region. So you can pay attention to the column with the CFRs and the column with deaths per million. The last column is essentially just giving us a little bit of an orientation in terms of how far that region or country is in terms of their epidemic projection. Again, here we have the data for Africa. Unfortunately, I think I'm not able to see a few of the things at the bottom there, but you can see the CFR ranges around 3.3. So these three countries which I've highlighted here, Kenya, Nigeria, and South Africa, those are the three countries that I picked in Africa to essentially just give a sneak preview of how their CFRs are ranging. And most of these countries are just doing above the third month of their respective outbreaks. If you look at Kenya and Nigeria, quite comparable. South Africa, the CFR is a little bit lower. We know that South Africa has done much better in terms of the testing. If you look at the deaths per million of the population, then
So it looks like we lost Dr. Ngere.
Dr. Ngere, we lost you for a while there.
Are you able to hear me?
Yeah,
Yes,
now
back.
I can get you.
Sorry, I think we just had a small power outage, but I think I'm back on. So if you can hear me clearly, I think we can proceed.
Yes, we can.
The second thing, oh, thank you, Prof. So the second thing I want you to look at in this table is the regions, Americas, the Africa, and the world. In terms of, again, the CFRs, which are highlighted in this column, and then also the deaths per million of population, again, looking at how far they've progressed in the epidemic response. There are also three countries here, India, New Zealand, and Australia, which are also countries that I'm going to talk about. Again, look at their CFRs, their deaths per million, and in terms of the evolution of the epidemic, the number of days since the first case was reported. So I'm going to refer to this table a lot, and in some of those instances, I'm going to put this data there so we'll have see them again. So this chart is picked from WHO and essentially gives us sort of how the trajectory of the epidemic has progressed by the WHO regions. And I want you to look at Africa, where we have about, we had about 216,000 cases. And Africa is represented by the blue color, and you can see the curve for Africa in terms of the cases reported a day has remained fairly flat compared to other regions. We have Southeast Asia, which is shown in purple, and you can see the curve is a bit steeper compared to Africa. But then, of course, we have the very steep curves from Europe here, and then we also have the region of the Americas, which has the biggest or the steepest curve on that slide. So this essentially just gives us a perspective in terms of how the African epidemic has progressed over the past months since the first case was reported in China. So 4 months after we had the first case in Egypt, our curve in Africa has remained flat. And this is despite Africa also having the highest burden of infectious diseases and also conditions like malnutrition. We know we have the HIV, the TB, malaria, and a lot of these conditions are also associated with decreased immunity in the people. So despite that, we still see a very flat curve in Africa. Our health systems have also been described as weak. We have overcrowding and poor hygiene in most of the urban slums and urban areas. And therefore, the expectation would have been, and I know most of us are aware about some of the predictions which were made much earlier, that the epidemic in Africa was going to be much worse. So the low numbers that we've seen, there are people who have they have tried to bring in explanations that it could be due to poor surveillance, although we think within our team that if we did have many cases, if we did have severe cases, if we did have deaths in Africa, then we could have easily picked those deaths using some of the surveillance platforms for pneumonias or even deaths around the region, which has not happened as far as the data that is available is concerned. So I want us to delve straight into the first hypothesis that we fronted, was fronted by our team to explain the low morbidity and mortality. So we had 5 hypotheses that we were considering, and the 5 are listed there. We have low seeding rate, or what we were calling a low introduction of imported cases. As we know, COVID was introduced mainly by air travel. So this hypothesis is going to explore how that played a role in the African scenario. The second hypothesis we explored in our publication was the effectiveness of the mitigation measures which were put in place to respond to the epidemic in many African countries. Thirdly, we looked at the population demographics of African countries compared to the rest of the world. We are looking at the youthful population in Africa and the role that it could have played. The fourth factor that we looked at was the favorable weather in terms of temperatures and humidity in Africa compared to the rest of the world. And the last hypothesis that we looked at was the possibility that persons who live in Africa could have had prior exposure to other coronaviruses, which could have given them some level of protective immunity. So I'm going to go through this one by one to look at some of the merits and also some of the reasons why we felt probably they may not be the main reasons to explain the trajectory in Africa. So the slide here, we have 2 figures here essentially. The figure on your left is looking at the volumes of air travel in the year 2018. This data is publicly available in the International Civil Aviation Authority website or even in the World Bank website. The charts on the right-hand side, on your right-hand side, essentially shows the confirmed cases of COVID-19, and the data is sourced from WHO website. So essentially, our thinking within our team was that if you look at this chart on the left, African countries largely contribute very little in terms of global travel. And if we look at absolute percentages, Africa contributes just about 2% of global travel in terms of number of passengers. That is data from 2018. 2019 data is still not yet available, but if we compare that with the rest of the world, then you can see that most of the African countries are within the range of less than 19 million passengers annually. Majority of the travelers you can see here, we have in Southeast Asia, places like India, Europe, which are reporting over 167 million passengers for that year, the United States, even South America in places like Brazil. Now, when you come to the right and you try to compare this chart with the cases of COVID that have been reported so far, again, you can draw a lot of similarities because, again, Africa appears to have a much lower case count compared to the rest of the world, where the case counts are a bit higher. So you see, again, Brazil, you can see the United States, Canada, you can see Europe here, quite dark. We also have Southeast Asia and India, also quite dark, because those are some of the areas where we've reported quite a number of cases. So our thinking is that because we had fewer travelers coming to Africa, then therefore the chances that we had introduction of foreign cases or imported cases, the contribution of that would be much lower than the cases that were sort of imported into the other regions of the world. The second hypothesis that we looked at was in terms of the mitigation measures which were put in place immediately when we had the cases of COVID. And that included travel restrictions, the lockdowns that we saw, and intensive case finding and other contact tracing mechanisms which were initiated by countries. So in Africa, as you remember, quite a number of African countries implemented either partial or complete travel restrictions. Sorry, I think I've lost my presentation there, but let me just.
So Dr. Ngere, can you hold on? It looks like we have a different video showing, so maybe you can hold on until it's corrected.
Okay.
I think someone shared their screen. Someone maybe on the panelists shared their screen and disabled Tungeres.
Are we back?
Yes.
Okay, so I was explaining that African countries implemented some of these measures quite early. In places like Rwanda and Uganda, as you can remember, lockdowns were implemented when cases were still in the digits. Kenya also implemented the curfews and the movement restrictions between cities and upcountry quite early on in the epidemic compared to other countries in Europe and even in the US, where the such measures were implemented once the cases had, accumulated. They were in the hundreds or in the thousands. So some of these internal travel bans also within countries also limited the number of travelers who could move between cities, even to the rural areas. And also, as you know, in the African continent, connectivity in terms of transport is not as good as the rest of the world. And therefore, with those limitations, we could also see maybe fewer and fewer people traveling from cities to the up countries. And probably that's the reason why the first part of the epidemic was mainly limited to the cities within Africa before it started spreading gradually to the other areas which are away from the cities. So with those measures in place, we think that it was easier for such countries to isolate, identify initial cases, trace their contacts much more effectively, and limit any pockets of transmission. And that played a role in terms of delaying the initial cases in African countries from picking up. I think some countries have done that much better, probably because their cases are still they're still reporting single-digit cases even up to now. We also have other factors which we thought could have played a part, and that is because African countries have also had some of the severest outbreaks in the past. Remember Ebola outbreak in West Africa. You also remember that as we were just beginning to report COVID, we also were having an active Ebola outbreak in DRC. Some people have actually said in other quarters that in some countries like in Uganda, for example, and even in DRC, they've been on an outbreak mode since 2018. So this was really not a surprise for them. Their teams were already active, and it was much more easier for such countries to mount a response. Also, some of those countries had a lot of capacity building during some of those outbreaks, and therefore they were able to respond much quickly. Again, I would also like to underline the role of the IDSR structures, that is the integrated disease surveillance and response structures, which have been put in place following the SARS outbreak in the early 2000s. A lot of countries in Africa are actually the ones in Africa actually have very good structures, including command structures, emergency operation centers, and the rest. And therefore, they were able to assemble some of these structures quite early on. We also remember that at the initial phase of the outbreak, we had a lot of innovations across African countries, trying to work around their testing, trying to work around things like the personal protective equipment, which helped some of those countries to mount some form of a response. Within our team, again, we explored some of the weaknesses, what we could call the weaknesses of that hypothesis. And one of the things which we brought up was that because SARS-CoV-2 is highly transmissible, we felt that probably only a few seeds would be needed, maybe in African countries, for the epidemic to take. Although that again is debatable, because currently we are seeing a lot of new information coming in showing us new things about the transmissibility of SARS-CoV-2. Another comment which we also had within our team in terms of how these two hypotheses could have played a role was that in African countries, as we know, our mitigation measures were a bit less stringent compared to the rest of the world. Our social distancing, our lockdowns, and even other measures were not very strong. And that was partly because Africa, again, in terms of the poverty levels, the reliance on the informal economic sectors, African countries could not sustain some of these measures for long. So we had the case of Kenya, where we've seen recently we are trying to reverse some of the measures. We saw the case of Ghana where they made an about turn and sort of reversed some of the initial stringent lockdowns. And even our neighbors, Tanzania, where now we are seeing social places are opening up and the economy is essentially opening up because a lot of these countries are also having other economic considerations to put in place. The third hypothesis that we looked at was in terms of the favorable demographic characteristics, in terms of the age of the population densities in African countries. And I've brought back this table again with some of the countries that we had seen. I want us to look again at this table and essentially to focus on the column with the median age of the population. So the two African countries we are looking at in this case, that is Nigeria and Kenya, you can see their median age, the population, that is the average age of the population is essentially below 20. And that we feel could have played a big part. If you look at the US, the median age of the population is 38. In Italy, it's 45. And in Africa as a whole, most countries have lower than 20. In Europe, most countries have 38 or more. Again, when you look at the case fatality rates for some of these areas, you find that it sort of conforms within those the median age of the population. So one other thing which we also know is that COVID has severe outcomes among those with the advanced age, and then also those who have underlying conditions. So we feel that this young age in Africa could have played a role in terms of blunting the severity of COVID in the initial phase. And that is because majority of the people in Africa are young and healthy, and therefore may not be able to, they may not develop the severe outcomes that we see in some of the countries, like in Italy, where we see the average age of the population is quite high. In fact, Italy is one of the countries in Europe with the oldest populations. Again, if you look at the density here, a lot of these countries are a bit comparable. The population density in Nigeria, quite comparable to the population density in Italy. Although if you look at the median age, that is where the difference is. And then you can see this, the huge disparity in terms of the case fatality rate that is reported. Again, in Africa, look at the case fatality rate is almost 3 times lower than what we have in Europe, and almost less than half of what we have for the whole world globally. So the two charts there again is still just trying to explain this point. We tried to plot the daily number of cases that are reported in US and Italy on the top chart, and the daily number of cases reported in Nigeria and Kenya since the beginning of the epidemic. And we truncated the x-axis from about 2 weeks. So we only have data here for the cases which were reported in US after the first 2 weeks, and Italy, and then down here also the cases that were reported in Nigeria after the first 2 weeks of the outbreak in Nigeria. So if you look at this progression, one thing which you need to take note of is that our y-axis are not comparable. We tried to blow up the y-axis for this lower chart so that we are able to at least appreciate the number of cases. Now, when we draw a line to show probably the first 2 months of the epidemic within these countries, I would call that maybe the first 2.5 months. You can see by 2.5 months after the first case in the US, they were reporting something over 30,000 cases in a day at around that time. If you look at the case of Kenya and Nigeria, 2.5 months after the first case was reported in Nigeria, we were just having just about 350 or so cases being reported each and every single day. So that again is subject to some other discussions in terms of maybe which countries are testing better. But then this just gives you a sneak preview that in some of these countries also they were testing, but 2.5 months down the line, we are seeing the curve for Nigeria and Kenya is a bit, is quite flat. We also went further and plotted the case fatality rates for these 4 countries, that is US, Italy, Nigeria, and Kenya again. And if we ignore the noise in the first part of this chart, as you know, CFR is very, very sensitive to numbers, and therefore when we still have few cases and fewer deaths, the CFR seems to jump a bit around. So we can ignore that first part. But then when you look at the trajectory, like in Italy, the CFR has just been rising quite consistently, and now it seems to be leveling off at around 14. If you look at US, which is shown here by the red line, again, you see the CFR has been rising and sort of stabilizing now at around 4.9, around 5, which is sort of in line with this dotted curve, which represents the CFR at the global level, if we now consider all the countries globally. The line for Kenya, which is green, and the one for Nigeria, which is shown by the black color here, are essentially mostly below the world average consistently, and now they seem to be stabilizing just slightly over 2%. So we think that the population age structure in Africa could contribute to fewer deaths, since we know that mortality, as I said earlier, occurs mainly in the elderly, while Africa has a younger population. There's one specific study which now tried to compare equally sized population across the age groups, sort of what we call the standardized mortality ratios, to compare the relative number of deaths between equally sized populations, now trying to standardize all these different populations and age groups across the world. And it found that there was a 4-fold reduction of deaths when Africa was compared to Europe or even to North America. And when we compared Africa to Asia and Latin America, we had a 2-fold reduction in deaths, which essentially means that Africa had, twice as fewer deaths when compared to Asia, or 4 times fewer deaths when compared to Europe or the US. So some of the critiques or comments that we received for that hypothesis included that the contribution of the youthful population could have been blunted by other underlying factors. We know that the prevalence of malnutrition is higher in Africa compared to the rest of the world, and therefore, in as much as the population would be younger, somebody would argue that that population, the immunity is maybe slightly lower, and therefore that young population may not contribute as such. We also know that in Africa, and essentially in the urban slums, we have quite, people who engage in risky livelihoods, or even some cultural factors and overcrowding, which might sort of blunt out the effect of the young population. Again, we also know that when young people are infected, they are mostly asymptomatic. So when we don't test adequately, it may not be possible to know the true extent of the infection. Currently, we still don't have any prevalence studies that have delved into the African countries to look at the maybe antibodies or even the true extent of infection. And the feeling is that without that knowledge, we may not be able to know whether these young people in Africa were infected, but they did not develop disease, or they are yet to be infected. So as the testing in Africa is catching up, then I think a lot of this is going to become more clear. The fourth hypothesis that was fronted by our team concerned the warm and dry weather in Africa, which we think could be decreasing the transmissibility of SARS-CoV-2. The map on the right-hand side essentially shows the average temperatures in Africa between December and April, which is essentially what I would call the first 4 months in the year. This data was averaged for a period of 10 years between 2004 and 2013. And as you can see, it's against the key, majority of the countries in sub-Saharan Africa, within the sub-Saharan African belt, actually had average temperatures between 25 and 30 degrees. It's only a few countries in North Africa that probably had much lower temperatures, but majority of the sub-Saharan African countries within the first 4 months, which is also the same time that the pandemic was just developing globally, a lot of these countries had higher average temperatures. And even within those higher temperatures, the annual variation of the temperatures between those 4 to 5 months were essentially quite uniform across the board. Our team tried to relate this with also some of the data which is available publicly. And we've seen from publications on respiratory diseases like influenza, which have shown that high burden of influenza is usually experienced in winter. And in most of the times, it has been associated with the increased viability of the virus during those winter months. Also, we know that during the winter months, we tend to, spend more time indoors, in closed spaces. And the thinking is that within those spaces, the transmissibility of some of these viruses is much higher. Also, we need to remember that within those months of December to April, most of the countries in the Northern Hemisphere are actually experiencing winter. And we saw the severity of COVID was much worse for the Northern Hemisphere countries where they were experiencing winter. We also know that from some of the past epidemics that we've had, like SARS-CoV-1 in the early 2000s, the H5N1, and even the much more recent one, the Middle East Respiratory Syndrome coronavirus, a lot of these respiratory viruses, despite causing cases throughout the world, did not cause many cases in Africa. Some of them are still yet even to cause a case in Africa. Like MERS-CoV, we had majority of the cases in the Middle East. And despite those camels being thought to originate from Kenya, where we also do some studies, we've not seen widespread human infection as has been seen in the Middle East. We also have some lab studies which have shown that SARS-CoV-2 is less stable in hot environments. And if you subject them to temperatures beyond 25, then the virus actually loses its viability. There's in one of these recent studies which have published the effect of temperature on COVID, data from 200 countries was correlated to look at the temperature, the correlation between temperature and the number of cases reported, and it was found that higher temperatures are associated with lower caseloads in those countries. And I think that data is quite comprehensive, and that really gives us an idea of how temperature and humidity can affect the respiratory viruses. The table here, again, I've picked some of the countries which had shown slightly earlier. And we are looking at some of the countries also which had the warm weather between April and December, between December and April 2020. And the three countries that we picked here that I'm going to focus on is Australia, New Zealand, and India. Brazil also fits in this list because it's outside Africa, but it also experienced those high temperatures within December to April. But then when you come now to look at the cases here, you will see that the cases at the CFR for Australia and New Zealand, and also to a large extent, India, have remained below the global average, which is about 4.9, but we are having Brazil here, which is quite high, and I think Prof is going to talk about that a little bit. And part of the thinking we have is that, as you know, Brazil is one of the countries that struggled to implement their mitigation measures at the initial phases of the epidemic, and I think currently their epidemic is evolving much faster. Their numbers are actually the second globally in terms of the total number of cases. So this hypothesis was criticized because when we draw the picture, the pandemic picture in 2009, when we had the H1N1 influenza outbreak, many parts of the world were affected, including Africa. And people thought that this actually became seasonal much later on. There's also the school of thought whereby some people feel that H1N1 could have been present in some of these areas even earlier, before the global pandemic. We also have some studies that have published mixed findings in terms of the effect of temperature and humidity, and that alone also tells us that probably this particular hypothesis needs also to be investigated further. We also have the case of Brazil, which to some extent we feel is not following the trajectory, but as I said, Professor Njenga is going to delve into that a little bit. Now, the last hypothesis that our team looked into was the role of prior exposure to coronaviruses and the role that would have played in terms of giving the African population some immunity. We know that zoonotic viruses, like some of the zoonotic viruses which are transmitted between bats and even humans, have been known to exist in various parts of the world. And when they spill over, some of those viruses can infect a small portion of the population, which might lead to development of some level of immunity. In African countries, for example, we know there's continuous contact between livestock, animals, wildlife, and humans in many parts of the rural Africa. And because we know that sometimes in some kinds of viruses, like the Ebola virus, we've seen whereby antibodies developed against one group of viruses or one category of viruses could confer immunity through cross-reactivity to other viruses. And I think that has been demonstrated quite well with the Ebola virus. So we feel that probably because of these past exposures, African populations could have had these exposures, and this could make them have some level of immunity from past exposures. So we looked at this one chart, which is just trying to explore a little bit of that concept. This chart was developed by Bradley in 2016. And when you look at it in terms of the scale, the deep brown shade shows areas where we have high bat-human shared viruses. For example, the parts in Africa which are deep brown would mean that we have even up to 16 viruses which are shared between bats and humans. And then you see that belt sort of crosses these areas within the tropics, a little bit in the Caribbean and Latin America. And then also we have parts of North Africa sweeping all across the Middle East, India, and countries like that. We think that some of these regions, because of this high prevalence of bat-human shared viruses, the populations there could have been exposed to some of these viruses in the past, and that possibly could have led to some level of immunity through the cross-reactivity, and that would protect some of these populations. However, there are also members of our team who feel that because we've not had any novel coronavirus outbreak in this region or in Africa, then that would really discount such kind of thinking. We also think that the effects of prior immunity, if it was there, then it would have played a part in the epidemic that we saw in China, because we know in China is one of the areas where we have the largest population of bats. We also have a lot of these bat coronaviruses which have been isolated in such places, and therefore if it played a part, then we should have seen such effect also in countries like that. And therefore that's one of the arguments which we feel is not working for that particular hypothesis. So in summary, members of our team felt that a combination, not really some of these factors in isolation, but a combination of factors is likely a plausible explanation for the initial epidemic trajectory that we saw in Africa. A lot might change, but we feel that the combined effects of weather and the youthful population in Africa could be a more compelling explanation for the low COVID transmission and severity that we saw in Africa within the first 5 months of the pandemic. We also feel that other factors which sound very exciting, like the role of pre-existing immunity, even the effect of temperature, and even some other hypotheses which have been floated, might need to be looked at in further studies. But then at the same time, I think because this is information which has been stressed upon by various agencies over and over, is that Africa still could experience increase in cases as the epidemic is progressing. And we've seen that happening in Brazil. That is simply because as the epidemic continues to grow, then new factors and new things might become more relevant, and we might see some of these hypotheses sort of being much more clear. So we also have other hypotheses which have been fronted by other quarters. A lot of this, we did not explore them in our publication, and that is because the authors felt that some of these really were not plausible enough to explain the trajectory that we were seeing in Africa. One of them was the people who have been fronting the BCG theory, which we feel, because the BCG really plays a large role in children, maybe in respiratory illnesses, including and bacterial, but now the raw question. We also had the the theory that we have this S2 receptors in Africans, which is much less expressed compared to the rest of the world. But I think that is not true, given that in places like in the US and in Europe, the African Americans, all people with African origin, have been shown to have much more severe outcomes of COVID compared to others. We also have the vitamin D deficiency theory, and even the low prevalence of NCDs, non-communicable diseases, which have been floated in other quarters, but our team really did not consider that compelling enough to be included in our review. So that is our presentation. As I informed you earlier, I'm going to invite Professor Njenga to briefly talk about the evolution of the outbreak in Brazil, especially beyond our publication, and then we can open the floor for questions. Thank you very much.
Thank you, Dr. Ngere. I'm just going to take 2 minutes because I know there's a lot of questions. I've noted a number of them already. In Brazil, if you look at our presentation of the argument that weather and youth population are probably the most compelling theories that explain the low transmission and low case fatality rate in Africa. The countries that we compare that with, including India, the second most populous country in the world with about 1.3 billion people, only behind China. Also, there was sort of prediction of doom and gloom when this pandemic got there. But so far, they have also had very, very low rates. As you can see there, the number of cases are pretty low, and also the case fatality rate has been quite low, even though their median age is about 29 years. Also, Australia, we compared that, which essentially have the age category, which is fairly comparable to Europe and the United States, except for the fact that they had warmer weather. And again, they had pretty low transmission and very low case fatality rate, making a very strong argument that weather is a very significant factor in the transmission and outcome of this disease. The only outlier in this has been Brazil. Brazil is, as all of you know, is one of the largest countries in South America. They started very low. They had very few cases for the longest time, but in the recent past, they have overtaken the US in terms of deaths, and also their case fatality rate, as you can see, is now at 4.7, almost along the global average of about 4.9. We think that the main factor that has contributed to Brazil is the lack of mitigation factor. If you've read the politics all the way from their political leadership, they never really implemented any of the mitigation measures that have been implemented everywhere. And we think that's a major contribution. And that also argues for the fact that even though Africa had a youth population, even though Africa had warmer weather, the mitigation measures that the governments are implementing, including Kenya, are still important in controlling the spread of this disease. Otherwise, we could easily go the Brazil way if we do not implement mitigation measures and lie back and say, because we have young population, because we have good weather, then we should sit back. I think Brazil is a pretty good case in point to argue that mitigation measures work well. The other factor that may have contributed to Brazil is the air travel, the first hypothesis that Dr. Ngere explored. If you looked at the chart that he showed, air travel, so Brazil is the most frequently traveled country in South America. And that may have meant that there was very high seeding of COVID-19 in Brazil. And so as the lack of mitigation measures happened and these small pockets of cases spread across the country, the pandemic seems to have spread to a level where the government is unable to control it, and now it's out of hand. Right now they are leading in terms of daily cases and also deaths, partly because they did not implement any mitigation measures. And I think those pockets, because of high travel rate, may have led to the cases that we are seeing in Brazil. That's probably the main outlier that we have in arguing for weather. Youthfulness, I think there's not much of other countries that we can compare with, because Africa is pretty young compared to other countries in terms of age. And I think with that, I'm gonna stop there. I think the moderator wanted to moderate the questions. Is that the way you want to go?
Yes, that's okay. Thank you so much, Professor Njenga and Dr. Ngere for your very wonderful presentation. It seems like Africa is God's favorite. I don't know for those who believe that, or is it too soon to be excited about the low numbers? We will find out. Thank you so much for that. Before we go to the Q&A, because I can see most of the questions have actually been addressed in the presentation. There are issues of BCG, there's issue of the low numbers. Somebody asked that they'd love to know about the low numbers. Can we hear from maybe Dr. Maritim? Dr. Maritim, would you like to say something?
Thank you so much, Dr. Kalundu, and thank you so much, Prof. Kariki Njenga and your team for this excellent presentation. And I'm just listening, and I was writing my notes as I went through the presentation, and really looking at the 5 hypotheses really that you've explored in great detail. So I feel that your paper will I think when we've gone through the peak, then we'll reflect back and see, was the paper too early, or does the paper really predict where we are headed? And it's good that you've highlighted about Brazil, because every time I'm in, for example, the task force meeting, I feel that we should not forget Brazil. I had the opportunity to study in South America, and it's a country that's really, like most of the continent, I went to Peru. So most of the continent, Brazil, Peru, they're actually in the tropics. So therefore, it's more like the weather patterns are similar to Africa, and it's just a matter of time. To me, I feel like this epidemic is still going through across the various continents, and the more recently affected continent overtakes the other continents. And we've seen that in China. We've seen Europe was slightly lower. Now it's in the Americas. And maybe the next port of call is really Africa. And I think you've clearly highlighted that the early institution of mitigation strategies flattened the curve, but we know we just have a short time before 6th of July when the country may be reopened. And therefore, what does this really mean for us? Looking at the 5 hypotheses that you've looked at, introduction of disease, what does introduction mean now? When we open up Nairobi and Mombasa, will there be a lot of introduction to different counties that maybe already have few numbers? What does that mean as we think of reopening? Mitigation strategies, I think, really helped. But for most of the non-pharmaceutical interventions, they are as good as they are implemented. The moment you relax on them, then you sort of like lose the battle. And when you're talking about even the travel restrictions and the curfews, they've sort of contained the disease in the areas where it was introduced, largely within Nairobi and within Mombasa. And therefore, what does it mean when we reopen Nairobi and Mombasa? What does it mean for the rest of the country? When you look at the population age group is more important in determining severity of disease, has been very well presented by Dr. Ngere. Maybe not so important in terms of saying who's more susceptible, because we even know children can still get infected, but they don't transmit the disease maybe fairly much, and maybe they don't also suffer from severe disease. So when you're talking of population and the age structure, it's more in determining severity of disease, and the people who will get more severe disease are the people who are 60 years and more and older than that. In terms of weather, again, maybe neither here or there, and even as we think of reopening, most of Kenya has generally the same weather patterns. Only July maybe is our coldest month. So we may see more increases of cases maybe around July when people are more indoors. But I think in most of the other countries, even the use of air conditioning and warm, like room heating during winter, maybe could have contributed to dissemination of disease within the indoor settings. Prior coronaviruses, again, neither here nor there. So I feel like your paper, maybe at the time when it was written, may have described the situation, but again, we are watching the outbreak as it evolves. And currently, maybe our numbers are still low, but as we think of reopening the country, what does that really mean? Because it means that most of the non-pharmaceutical interventions will have been lifted, maybe lack of aggressive contact tracing. Now we are moving to home-based isolation and care. What does that really mean in terms of clustering of cases, for example, within the household? Those are just some of my comments, and I'm hoping that maybe the team can respond and really give us a way forward in terms of what can we learn from the intensive research and interrogation of the data to help us even as we think of reopening the country. What can we do differently? Thank you.
Thank you, Dr. Maritim, for sharing your sentiments, and we hear you. I'm sure the team will be able to address your concerns very soon. Dr. Odhiambo, would you like to make a comment?
Thank you, Rhoda. Sorry, I wanted to show my face, but I realized that I have a previous background from another presentation, which does not belong here. So I will not show my face to the great presenters. Let me congratulate this great team, Professor Kariuki and Ngere et al., for this masterpiece publication. I was quite impressed that it came very, very early in appropriate time and addressed some of the issues. Obviously, this is a very good publication, and as Dr. Maritim has highlighted, is probably some of it remains to be seen, but academicians and researchers like you must initiate this debate. The questions I have, which I think either you or even Dr. Maritim might have to say something about. First, we acknowledge, obviously, that so far, the pattern of this disease in this subcontinent or this area of the continent is different. The case fatality rates that have been shown is obviously low. We have now been in this for over 4 months, and even when we compare the patterns with the other countries at this particular period in time, we still are doing much better. I do not know why there is not any mention of, or it is deliberate, that Tanzania, with which we should also compare a lot, and where unfortunately or fortunately we can say there was a bit of a similar leadership like the one of Brazil, has remained the way it is. And even though in the social media talk, everybody says how the situation is bad in Tanzania, when we talk to some colleagues in Tanzania, we do not see this pattern. And therefore, even when we are extrapolating the Kenyan situation and trying to see what would happen in non-response, we remain to be convinced that indeed our trajectory is towards Brazil, because we would be seeing that the trajectory in Tanzania should be ahead of us in that direction. So maybe I would like to hear what the panelists or what the Dr. Kariuki and Dr. Ngere thinks about that. The other one is that when we closed Isili, when there was an outbreak, and we expected as a cluster area, obviously we should have seen a bit of a spike in that area during closure, which could have also justified and said, look at what is happening at the area we have closed. And that is, we have locked the disease in that particular area. But we have not heard whether there were increases of pneumonia or fatalities or chest infections in that particular area. This therefore leaves us to ask, the similar pattern also applies to the old town of Mombasa, whether after closing these areas, was there any spike that was observed? So with this, I sometimes wish to play the devil's advocate and ask the scientists here that is there not a justification of a difference in approach to our response? Thank you.
Thank you, Dr. Walter Odhiambo. Thank you. Professor Njenga, Dr. Ngere, would you like to address those concerns before we go to the Q&A?
Okay, thank you, Chair, and also thanks Dr. Maritim and Dr. Odhiambo for your questions. I know mostly, I think Dr. Maritim, you had very good comments about the presentation, and I might want to split these responses between myself and the team So I'm just going to give a little bit of a response to your question on, I think this was a comment that the paper came early, but things may change. I think what I can say just quickly to answer that is that yes, this paper came early, as I said earlier on. One day in COVID is, it can change so many things. 1 week can actually change a trajectory of the epidemic by far. And therefore, as things develop, I think some of the theories or even the hypotheses which have been fronted, even different from what we have here, they've been falling, by the wayside. What we know is that as the epidemic continues, the picture might become more clearer, and we may be able to know for sure whether some of these hypotheses that we put forward were major in terms of their contribution to the epidemic. You asked a second question on what the data means for when the country should open up. And I think that's really a difficult one to respond to, because again, all these findings that we had in our publication, including, all the other information which is available from modelers and from other teams that are working together with our policymakers, I think all these have to be put into perspective as we make public health decisions. There's always a lot of excitement when you talk about, some of the hypotheses which we brought forth in the publication. It brings in a lot of excitement when you say that Africans are a bit younger. That really is quite reassuring. As Dr. Kalundu said here, that Africa seems to be lucky. I don't think she's the only one who has that kind of a feeling. But what we would like to stress is that a lot of all this data has to be put together for us to arrive at a good decision, because then you remember that things change. As Professor said, Brazil was having a trajectory which was quite much similar to African trajectory in the initial phases, but then at one point, things just snapped, and now they are the second highest in terms of total cases, and they're also reporting the largest number of new cases and also deaths globally. So I think things can still change, but then a lot of this information should really feed into some of the policies that we are making. For example, we've seen a rising, voices which are saying that countries should abandon, the total lockdowns, and instead we need to adopt an approach where we protect, the segments of the population that are vulnerable. So I think a lot of that can also be used maybe to our advantage in African countries. Kenya, for example, a majority of our population is young. Are we able to identify the old? Is the government or are the policymakers able to have policies which can protect the vulnerable members of the community? And those protections enable the rest of the economy to open maybe in a sequential manner? Those are some of the questions which can be answered as we enter this phase where we are rolling back on some of the measures that have been put forth. So I want to invite Professor Njenga to make a comment on the case of Tanzania. I think that was a question from Dr. Walter Odhiambo. And also the second question from Dr. Walter Odhiambo was whether there's justification for change in approach on how we are responding to the epidemic. Prof, welcome.
Yeah, thank you, Dr. Ngere. I think you're getting used to giving me the questions, the hardest things that cannot be explained rationally, like Tanzania. But just to go back to Dr. Maritim's question, what happens when we reopen as I go to Tanzania? I think I would ask the question back to Dr. Maritim. What are we looking for to open? What are the indicators that the government is looking for to say that now it's safe to open? We know that testing is sporadic, it is not systematic. And obviously, if you look at the number of cases we are testing, as we test more, we are finding more cases. So are we waiting until the number of cases we test go down? The testing that we are doing is not an indicator of the severity. It is an indicator of community transmission, but does not give us the numbers of where this disease is in the community. So come 2 weeks from now, when the team meets the president, what are we looking for to say either open or do not open? Are we looking for the cases to go down? They're likely not to go down. So what is going to be the signal for us to open the country? And I think that's a big question. Maybe the bigger question is, what is the outcome Kenya and the world is looking for before we can move on from this pandemic? I think the only outcome the world is looking for is herd immunity, time when all these viruses to go away. Clearly, I don't think it's going away. So we are looking at a time when a large population will have been exposed to the virus, either through vaccine or through infection, and therefore we are immune, and that ends up protecting the rest of the population, even those who have not been exposed. Now, what we know about coronaviruses, for that stage to be reached, we expect about 60 or 70% of the population to be infected. But even though that number looks very high, even if we had 30% of the population infected or 40%, it does confer population protection to the country. So I think as we look to reopen, I will ask the counter question, what are we looking for? So I think in the end, whenever we open, whether it's in 2 weeks or in 5 weeks, the cases are still being reported. I think the question is, how are we going to open up and what mitigation measures are we going to bring in? Tanzania is an interesting country. If you look at Tanzania, they are not testing, so we don't know. I think they probably, I would argue, again, I'm a scientist, I'm allowed to make hypotheses, I just don't own them. So if they are wrong, I abandon them. So I think in Tanzania, what I would argue is that they're likely, if they were doing good testing, they probably would have as many cases as Kenya has or other countries have, just that they're not testing. But because they also have a young population, the number of deaths may be also the same level like we have in Kenya. So there is no information right now to indicate that Tanzania is at a better place than Kenya or is at a worse place than Kenya, because we do not know. But if that is the case, then the mitigation measures in Kenya are important, given that Tanzania is doing nothing. They are reopening schools, they are reopening everything. It's a good debate, it's a good discussion. I think for me, the argument is we need mitigation measures, but actually the youthful population, and to some extent the weather, are playing a role. So I would argue that going forward, because we are never going to see very severe weather, even as we go to July, this pandemic is going to be largely weaker and lower in Africa compared to the way it was in Europe and America. So I'll hold that hypothesis until I'm proven wrong. Up until this point, that hypothesis still holds strong. My last comment is on the question of any cases of infection. There's a lot of news information in the news that you can get reinfected many times by COVID. I think that is where we scientists, if you look for something, you're going to find it. If you look at areas like New York and areas that have had major cases, or Italy, when they reopen, there really is no information that shows a pocket or a hotspot in an area where they were exposed and the disease has come back again. So it is safe for us to assume that if you get infected, you are likely going to be protected for months or at least a year or more from COVID-19. There is no data that has dispelled that hypothesis today. Thank you.
Thank you so much, Professor Njenga. Thank you so much, Dr. Ngere. You've answered the question. There was a question about herd immunity. You've answered it. There are a few questions about Tanzania. You've addressed them. But you've asked a very pertinent question. How are we going to open up? What indicators are we looking for? I can see Dr. Loisa Cheng has joined us. Dr. Loisa Cheng, kindly indulge us. That question from Professor Njenga, it's a very valid question. And
it is a valid question.
Yes.
And I do not have an answer. I think one of the things I'm learning, especially over the last few weeks, and today morning I've just done an ICU round on very sick patients, some fairly young with no comorbidities, but very sick with COVID. And it's easy, I think, for someone who's not on the front line and actually seeing COVID to argue otherwise. But one of the things I've learned over the last few weeks, and one of the changes we are seeing, is we're beginning to see much sicker patients. As of today in Kenyatta and Bagathi, we have just more than 10 very sick patients. If you asked me this question 2 months ago, all the patients were well, would say hello, do the round and move on to the next patient, and would say hello, tell a few stories and laugh and move on. But we're beginning to see the other face of COVID that we'd hoped we wouldn't see. So at this point, it's not so much the numbers that are announced by the cabinet secretary every day. We really should start focusing on what mortality are we seeing and how sick are the patients that we're seeing getting. And I'm not sure what's going to happen over the next few weeks. Our projections are that as the numbers go up, the population that's sicker and dying is also going to go up. And I guess we can open when we've segregated those who we agree can die and the rest of us can move on. So this is a difficult question. I do not know the answer to it. What I know for sure is that right now we reopen. I mean, there's a lot of pressure to reopen right now, and we reopen right now, but we just need to be prepared to deal with the number of severe cases and mortalities that we'll have, because that's coming for sure. And if anything, if what we're seeing now is anything to go by, if it goes higher, our facilities are going to get overwhelmed. As of today, I do not have space to take an extra patient who requires ICU for COVID because we are full. That's something that's going to be replicated in many other countries. If someone in KNH right now was severely ill and required ICU and they had COVID, we'd have to either look for another facility to send them to, or they will die. So I think even as we look at figures and think how we are doing well, the reality is we're also seeing very sick and dying patients right now. Thanks, Rhoda.
Thank you, Dr. Lisa Cheng, and thank you for bringing us to the reality that the picture has changed. And the fact that we're now having home-based care for asymptomatic patients, we're having the more sick patients coming to the facility. And the community spread, which Professor Njenga has clearly said, the testing is an indicator of community spread. Every day we see those numbers, that's the indication that the disease is now at the community level and it's spreading very fast. Dr. Ngere, there's a very interesting question about the weather. And somebody is saying there are more cases in Mombasa than in colder areas like Nyeri or Nyandarua. So is the weather still playing a role? And is also comparing Egypt, Algeria, Tunisia has more cases than in sub-Saharan Africa.
Okay, thank you, Dr. Kalundu. I think I've seen that question, and I've also picked a number of participants who are also asking the question on testing, whether our opinions considered also the testing, the number of tests that countries have been able to conduct. So maybe I'll just delve a little bit onto the weather. The case of Mombasa, one of the things which actually strikes in the epidemic trajectory in Kenya is that the initial majority of cases were mainly in two hotspots, that is Nairobi and Mombasa. Initially, we also had quite a number of cases from Kwale. We all remember the Kwale case, but then that Kwale, I think, based on the data which is available, it looks like they've, Kwale and Kilifi, they've sort of tried to control the epidemics. Now, my thinking is that the initial cases that we were seeing from Mombasa could have been as a result of seeding, what we were calling the introduction of imported cases. And probably Mombasa is one area which received quite a large amount of seeds at the beginning, and that's why the epidemic was able to hold and continue to spread. When we bring in the explanation of weather and essentially temperature and humidity, what we are trying to say is not that weather and humidity stops the virus, it essentially slows it down in terms of the transmissibility. So it might reduce the number of people who get infected from one maybe infected person, but it may not stop it altogether. And that's why Professor Njenga has highlighted the case of Brazil, which even has a hotter, more humid weather than majority of the parts in Africa. Brazil, has Amazon, basin, which is usually very hot and humid. And therefore, that may not be the only reason which can explain the low cases or even the escalating cases. So what we would like to say is that you have to have a combination of weather, but then you have to look at the mitigation measures. So if we don't mitigate, if we don't practice things like social distancing, if we don't do good contact tracing, then weather alone may not slow down the epidemic, but it can play a great role, especially if other mitigation measures are put in place. In colder areas like Nyandarua and the rest, again, I would just say it's seeding. Maybe they did not receive the initial seeds in adequate numbers, but then as the epidemic evolves, we might be able now to see once those areas start having community transmission. If they do, then we would be able to see the pattern that we have in some of those cold areas. I would also like to respond to this question about testing, because I've seen many people asking whether our hypothesis also considered the number of tests or the level of testing in these various countries. Now, what I would like to say is that testing is a bit of a challenge to describe. And the reason being that most of the countries, if you look at the testing that has been done, the figures are there, they're available. And in Kenya, I think we've done just slightly less than 150,000 tests as of yesterday. But largely testing is dependent really on the policy that a country decides to develop. There are some of these countries which do mainly targeted testing, so they really test the high-risk people. There are other countries where the testing has, reached the stage where they're doing a widespread testing at the population level. And therefore, the kind of numbers that you might see may not be still very representative. For example, if you look at Kenya, currently we get one positive case for every 27 tests that we do, roughly. If you look at places like maybe in the US and even in some parts of Europe, they get one positive case maybe for fewer number of tests. And that is because probably in some of those countries, you find that they're doing very targeted testing. In Kenya, you find that, again, our testing regime might be different because whatever we consider as high risk and we test may not be high risk in other countries. There are countries where they have this universal testing, where they have to test, institutional people in institutions, even in areas where they've opened schools, where they've opened, sports, and the rest, they start testing and they have, this periodic testing maybe after every 2 weeks or every 3 weeks. And those definitely will affect the numbers that we see. Therefore, we did not delve into that because, again, testing is a matter of policy and probably resources. But what we know is that you cannot miss for example, the cases or even the, clusters of pneumonia or even the deaths that might come as a result of, widespread community transmission of COVID. Thank you.
Thank you, Dr. Ngere. Thank you for that explanation. There's somebody who's asking, now that age is a protective factor for Africa, the population is more youthful, should we comfortably reopen schools? I don't know. I really don't know whether that, maybe Dr. Ngere, you can clarify again about this age issue, because it can now be used to come up with measures that might not be very, there's no sound?
Maybe before Dr. Ngere, I think it's important to mention that even when you say age is a protective factor, if it lowers the death rate from 2% to 0.1%, but the transmission is still so rapid, that 0.1% might be also large cases. Are we willing to tolerate even just 5 of our school kids or 20 of our school kids dying because of COVID? I think that's a question. The fatality rate is lower, but doesn't mean it's not there. And I think that's the question we must ask ourselves when we talk about that. And the same thing about the weather. The temperature and the virus is not a straight line. It probably suggests that when you have a temperature that is over 20, it's going to be lower cases, but doesn't mean that, for example, Mombasa, which is over 30, is going to have lower cases just because the temperature is 10 degrees higher than Nairobi. It's not a straight line. It's just a general indicator that warmer weather, which is a very broad range, is more protective than colder weather, but not just a straight line of relationship between severity of the disease or occurrence of the disease and temperature.
Dr. Kalundu, this is Jeanette. If I could just also add to the response about if children are at less risk of severe outcomes, should we open schools? Mm-hmm. We should also keep in mind that children don't live on their own. If they go to school, then when they come home, they're putting their parents at risk, they're putting their grandparents at risk, they're putting other people who are at risk of more severe outcomes. So when we talk about opening of schools, there's several issues that play, and definitely not just that children are young, so they should be okay. Over.
Thank you, Professor Njenga. Thank you, Dr. Jeanette, for that explanation. And I hope the participant who asked that question has gotten their response. We had a few participants who raised their hands. Neil will allow 2 to ask their question because of time issues. Nelly Omoke. Dana Ocheng, Josephine Kagunda, Elga Boyo, Lilian Wasike. Unmute yourself and ask your question. Okay.
Can I start?
Yes, Josephine, go ahead.
Thank you so much, presenters, for the model. I just wanted to ask about the BCG, because you mentioned about the effect of maybe some other viral infections that may be present in the African communities. And there has been a lot of discussion about the BCG that some part of the population got. Is there any data to support the argument, or what can you say about specifically the BCG vaccine?
Okay. Dr. Ngere?
Okay, thank you, Dr. Kalondo. So the discussion around BCG vaccine has been that there was, I think, an initial publication which, interestingly, still in a preprint form, which analyzed data across the world using the, the global atlas of BCG vaccination, and then tried to relate that with the COVID numbers that have been reported across the various countries and regions, and sort of made a conclusion at that level that BCG could be playing a role, because countries which have universal BCG that are giving BCG vaccination to all newborns, for example, majority of countries in Africa and even other parts like Latin America and India are having much less COVID, outbreak. Now, what I would like to say about that is that that initial thinking led to several studies which were initiated to look at the role of BCG. But then as the data has been rolling by, I think none of those studies has so far shown whether that effect is useful at a personal level. We have to remember that that analysis which was done for BCG was at a population level, and such kind of ecological studies may not give very useful conclusions at individual level. And that's why that data had to be backed by individual level, studies. I know there were some studies which were started in Spain and the rest to look at the effect, but none of them has reported any useful data so far. Now, also to go back to what our data is telling us, if you look at India, if you look at Brazil, both of those areas we have a universal BCG vaccination, and those countries like India now is having a spurt of cases, and therefore people also think that probably it was just an artifact. Sometimes ecological studies might show a useful correlation, which may not be very true at the individual level. So as the epidemic is rolling by, I think a lot of data might come in to either prove or to strengthen that belief. Then we also have to remember that BCG vaccine in itself has a varied efficacy. Some people say that if you administer it, the efficacy is 0. Some studies in India which showed that the efficacy is 0. In other places, the efficacy has been shown even up to almost 80%. So it's still very questionable whether that kind of vaccination can help, both the young and the old, but we know very well it works for TB, especially in children, prevents them from getting extrapulmonary forms of TB, and then also is very good for, preventing, and I think it played a big part in controlling leprosy cases. So beyond that, I think the effect of that in COVID may still need to be investigated further. The other issue, I think you mixed a little bit the question of BCG with the role of prior exposure to other viruses. And what we brought out in our presentation was that there could be some viruses that, African populations or even other populations in the world could have been exposed to, and those could lead them to develop antibodies or immunity, which can be cross-reactive across several species of those viruses. We gave an example of Ebola where, antibodies developed against one class of filoviruses can be effective through cross-reactivity to protect people from other filoviruses. So I think that is also something which is subject to research, and, people need to look at it to just see how important that kind of a relationship is. I'm not a virologist or an immunologist, and probably a lot of what I might say under immunology and virology might be contested. I don't know whether Professor Njenga could have a comment or two on the role of prior immunity in protecting people against COVID. Over.
Yeah, thanks, Dr. Ngare. I know we are running out of time. I think the prior immunity question and the hypothesis is still weak at best at this point. And that's largely because of the argument that if prior immunity is a factor, Southeast Asia, which has been the source of the last two coronavirus epidemics, SARS-CoV-1 and now this COVID-19 have begun there, then you could argue that that population there has also been exposed to many coronaviruses and they should have had some immunity, but the disease also was quite severe and they had to implement severe mitigation measures. So even though it's plausible, it sounds very attractive, it's hard to argue that all of us in Africa, homogeneously from north to south, are being exposed to viruses, and so we have some prior immunity. There might be some, but at this point, even though we want to investigate that, because it's a good scientific question, I don't think it's a very strong argument right now to argue why Africa is not having high morbidity and mortality of the disease. It's also a question that has been asked by a number of people, whether HIV-infected people, particularly those on treatment, are having having more resistance to COVID because of probably antiretrovirals. It's been a question that has been asked quite often. There's no data on this, and I think it'd be an interesting question to be able to explore. I don't think we have enough HIV-infected cases. Maybe people at the team can comment to be able to provide data on that. But it's a very interesting question.
Thank you, Professor Njenga. Thank you, Dr. Ngere. Maybe one more question from Japheth, Dr. Japheth Ayako. Dr. Japheth. Okay, so I don't think he has a question. So we'd like to appreciate the panelists for finding time today. Thank you so much for the good work that you've done. I went through your article when it was published, and I really appreciated it because it came at a time where we wondered whether the restrictions are helping or not, so it helped a bit. And it raised our hopes as Kenyans, or rather as an individual. Let me not speak for the rest of the 49 million and something. So looking at the hypothesis, it's only a matter of time before we prove whether it's true or not. And somebody has suggested that these are very good research questions. So we talked about low introduction of imported cases. We saw that the JKI is planning to open up domestic travel. Now their protocols are ready. Maybe by July, we'll have international flights coming in, tourists coming in for summer. So we are waiting to see how that will go and the effective mitigation measures. Sorry for that. Sorry for that. And also the effective mitigation measures, this we wait to see once the restrictions have been lifted, once we have a bit more relaxation. Is behavior change still going to be there? Are Kenyans still going to adhere to the measures that the government had put in place, the non-pharmacological measures? That's what we wait to see. And also the youthful population, that's a plus for us. It's good that our median age is 19 years, and we pray that that continues being our saving grace, the younger population. There's the issue of the warmer and drier weather. We're going to the cold months, but we appreciate that so far it has been great for us as a country. And prior exposure to coronavirus, we're in the belt, as you've seen from the map that you've showed us. We're in that belt where we're part of the countries that have close contact to these infections. Now, there's a very good comment from Professor Nduati, and she's saying the elephant in the room is the low testing rate, the weak clinical case definition, and many asymptomatic patients who are now walking around. So transmission can go on for long and can be undetected for long. So that's some of the concerns that as we leave this session, we have to go with. And I pray that the people who are listening from the counties will be able to put in measures in place as we appreciate this particular conversation we've had today, please put measures in your facilities in place so that you can be able to address the cases as they come in. As you hear from Dr. Loisa Cheng, who's on the front line, that the patients who are coming are a bit more sick than 2 months ago, 1 month ago. So let's prepare ourselves very well for that. From Eric Osoro is saying the number of severe cases is expected to rise as the outbreak sweeps through the country. Apart from school closures, movement in Nairobi has largely been unrestricted during the day. That's true. That's very true. So thank you all for attending this session. Thank you, Professor Njenga, Dr. Isaac Ngere, Dr. Jeanette, and the entire team for the wonderful work that you've done. We hope to see more and read more from you and learn more from you. As we are on the clinical side, we also hope to learn more and appreciate more. Tomorrow, we're going to have a very interesting session on pharmacological and convalescent plasma therapy. We'll be having Professor Omonge, Professor Anzala, and Professor Matilu Mwau will be taking us through that and whether we are in a position as a country to institute that form of treatment. So thank you so much for attending today's session. Thank you to the panelists for always finding time and aiding our call and coming to enlighten us more. Thank you to the participants. For those who have issues of regarding CPD, kindly send us an email, knhcpd@gmail.com. We'll be able to see whether we can address your issues. Asante sana. Bye. Have a good afternoon.
Thanks, everyone.